So before the breakout sessions, our first talk this morning, and we have 3 of them, will be presented by Dr. Michelle Keir, a cardiologist in the Aortic Clinic in Calgary, and she will address diagnosis and medical treatment of heritable thoracic aortic disease. Michelle?
Good morning. As Dr. Al-Hamzi said, I work in Calgary, so I work with Dr. Nanette Alvarez, who set up an amazing clinic there. And so I'm lucky to be her minion, but she was unable to be here today, so I'm going to give the talk on behalf of our clinic. So I'm just going to give kind of a brief overview of, so I'm an adult cardiologist, of how patients come to attention, and then how we go through the diagnostic workup, and then general management principles. So the objectives, so I thought we could kind of review ways that patients with GAD come to medical attention, and that's changed significantly over the past 10 to 15 years. Compare today's diagnostic paradigm with previous, and then review the tools we have available today to reach a diagnosis. So when you come to clinic, what information do we gather? What additional information do we need? And then how do we work through that with you? And then review kind of the tools that we have in our toolbox for treatment and management of genetic aortic disorders. So in the good old days, so I'm not making a case that Abraham Lincoln had Marfan syndrome, although there's a relatively good case to be made. So before genetic testing and advanced imaging were available, the thought was you would take a very good family history, we would do a lot of measurements, you would look at a patient, there was lots of complex scoring tools, and then the decision was maybe you do or maybe you don't. And I think that it was a lot less definitive than it was today, although we're still oftentimes not definitive. But I think this is important because I had a patient say to me yesterday, or last week, that so when he was a child, he was evaluated for Marfan syndrome at preteen, and he had some of the features but didn't meet the full criteria. So they said, "Yep, you meet criteria. You don't meet criteria, but you may have it." And he said, "Well, I found that whole process kind of demeaning because he was a preteen, and when you don't want to go in and somebody point out all the things that are different about you when you're a preteen." And so then he didn't come back to care for 30 years. And so I think that that's important, that kind of the way that we used to diagnose patients based on the physical exam and the scoring, we still do, but things have changed quite a bit, and that may have been stigmatizing in the past. So again, looking at the history of the Ghent Criteria, so initially it was the Berlin Nosology in 1986, and then became the Ghent Criteria, which then was revised in 2010. And this is still kind of the standard for clinical diagnosis of people with Marfan syndrome, not related disorders. But these are kind of the things that we look at, so the physical exam features and the family history to reach a diagnosis. So this was kind of the prior diagnostic pool. So even 10 years ago, the middle is kind of people that would come with possible Marfan syndrome or HAD, so who would come to cardiology attention or genetics attention. So it would be really people with a family history of sudden cardiac death or dissection. So I've got a couple people in clinic who, when they were children, their father had sudden cardiac death, and so they ended up in a clinic, and they were maybe seen once and measured and said, okay, maybe you do, maybe you don't, and then kind of go on and live with your life. So it was a lot more difficult previously. So family history of sudden cardiac death or dissection, physical features identified on exam. So people that really had a lot of the physical features or were easy to pick out with that kind of Ghent criteria would then come to attention. And then again, people who had an enlarged aortic root, and even 15, 20 years ago, the diagnosis was based on echocardiography and maybe a chest x-ray. Somebody would say you've got a dilated aortic root. So those were kind of the 3 pools of people that would come to clinical attention and may or may not come to clinical attention to somebody that had kind of any experience with genetic aortic disorders or Marfan syndrome and may or may not be followed. So that was kind of the pool that things were in the past. And then again, looking at our past algorithm, so you would take a family history, and again, we talked about family history yesterday a bit and how rife that is with difficulty, because a lot of people, may not have a family history. A family member had sudden cardiac death, but there's no real clear history there. Taking a past medical history, cardiovascular findings, so physical exam and imaging, and then non-cardiovascular findings, so the secondary features. So past medical history, so the things that we look for, we ask about. So on the left there is a picture of a huge pneumothorax. So this is the lung. So it's supposed to take up this whole space. All of this black space is air. So a collapsed lung. So we know that patients with GAD and with Marfan syndrome are prone to having collapsed lungs. So we always ask about history of needing a chest tube or having an air bubble in the lungs. The other thing is recurrent hernia. So this is a picture of a hernia. So these are things that we ask about on the past medical history. And it's surprising the number of people you say, well, do you have any past medical history? Have you been to hospital? And they don't remember these things because they're not related to the heart. They're not related to the aorta. And then when you specifically ask about it, and they say, oh yeah, when I was 12, I had a chest tube in my lung, but I was in emerge for a couple days and they took it out and it was fine. So these are the things that we specifically ask about on past medical history. Common cardiovascular manifestations. So the big things that we worry about. So I think it's a different kind of perspective because we worry about your heart and the things that can kill you and the things that can be a concern. Whereas I think the other multi-system part of the disease, we don't care as much about, right? Because we're worried about things that can be lethal, whereas I think the day-to-day lifestyle things are less of a focus for us. But so if you look here, so this is the aortic root. This is kind of a drawing of an echocardiogram, and so this is the area number 2 here, where you get dilation of the aorta in patients with Marfan syndrome and other related disorders. And then this here is the mitral valve. So this is the valve that pumps between the top and the bottom part of the heart on the left side of the heart. And this is a normal architecture of a mitral valve, and this is mitral valve prolapse. So you can see the leaflets are redundant or really basically floppy. And so these are kind of the two things that we worry about from a cardiovascular perspective that can happen over time. So these leaflets become very floppy and really leaky, and it can lead to heart failure. This aorta becomes very, very dilated, and you can get leaking of this valve, or you can get dissection of that aortic root. So these are the things that we look for, and sometimes this is how people come to attention, is because they have severe mitral valve prolapse and mitral regurgitation, and somebody says, oh, they also have a pectus, or they also are very tall. And so that's how people end up in clinic. So other things that lead us in that direction. So these are the ocular findings, and I think we'll have a talk later on that, of Marfan syndrome. So these are the other things we look for in the facial features. So the Loeys-Dietz, the hypertelorism of the wide-spaced eyes, the down-slanting pupillar fissures, the abnormal eye findings in Marfan syndrome. So these are things that we look for on exam. High arched palate. There was a lot of excited discussion with the group about bifid uvulas yesterday, which doesn't seem exciting, but for us it's exciting. The other kind of dental findings. So, a lot of times, so I have one patient who comes to clinic, and when you look at her, she doesn't have a lot of the physical features. And then she says, well, yeah, when I was 10, I had surgery for retrognathia to move my chin forward. I had a lot of my teeth removed. I have veneers. She had pectus repair when she was a young child. So, with cosmetic therapies, there are ways to really mask a lot of these things. So a lot of it is also just on history for the patient as well. But these are kind of the things we ask about. Did you ever have surgery on your jaw to move to get rid of your retrognathia, that sort of thing? And then again, kind of the skin findings. So with Ehlers-Danlos, the thin skin, the prominent veins, the livido reticularis, which is kind of that lacy rash here on the bottom. The stretchy skin, and then also the poor skin healing or the wide, thin scars. And so, we often ask people, my favorite question is, did you have any party tricks when you were a teenager? So can you pop anything in and out? Does anything stretch? And oftentimes we identify things that way. And then again, kind of the measurements. So the long limbs, the scoliosis, the telangiectasia, which is kind of an imaging finding, but can sometimes help. And then, of course, the pectus, excavatum, and the carinatum. But I think the important thing is that none of these particular features is, on its own diagnostic. There are lots of people that have a pectus excavatum that come to clinic and don't have any other features and have no family history. And so we end up not sending them to genetics, or genetics ends up not doing genetic testing. And so I think that the kind of focus on these physical exam findings is not what we focus on any longer as much. And then again, the wrist sign and the hand sign. I'm sure you guys have all done this multiple times in clinic. And then the feet findings as well. So the varicose veins, the history of club feet or contractures. So then where do we get patients now? So where is the current diagnostic pool? So I think that this is important because the numbers are increasing, which is good because people are adequately being diagnosed, but also the pools are quite a bit bigger than where patients would come to attention from before. So now people that come to attention kind of in the middle here, we still get patients that have a family history of sudden cardiac death or dissection. They tend to be referred more to genetics. And then now we get patients, quite a few, who have, a family member has come to genetics, they got a letter, they get genetic testing, or they have a positive gene. So as opposed to kind of the old paradigm where people would have physical features be referred to genetics, now it's coming in the opposite direction. So it's patients who are starting with a genetic diagnosis, and what does that mean? And it's really a different care paradigm. Abnormalities of the other vasculature identified on imaging. So now with cross-sectional multimodality imaging, we're getting a lot of people that have, iliac dissections of the arteries in the legs. They get brain imaging for another reason. Somebody gets an MRI of their brain because they have migraines and there's abnormal vasculature of the brain, and somebody says, oh, this is not normal. Maybe they have a connective tissue disorder. So we're catching a lot more people, whereas before the imaging tools were just the echocardiogram, which was that one measurement of the aorta, or the valve abnormality. Now we have cross-sectional head-to-toe imaging, and people get that imaging for lots of reasons. And sometimes, they go in for a chest cold and get a CT of their chest, and then end up getting diagnosed with a significant aortopathy. So the pools have changed quite a bit. So then again, abnormal aortic dimensions on multimodality imaging, so MRI or CT of the chest, and then still people who have physical features identified on exam, and a really great family physician says, hey, you have these features in a family history, so we're going to refer you. So the diagnostic pool and where patients are coming from has increased quite a bit, and the perspectives of where people are coming from has changed as well. And so that kind of also has to change the way that we treat people. So our current diagnostic algorithm, so pretty much, when people come from any of those pools and they show up in the cardiology aortopathy clinic, they kind of get put into this box of possible Marfan syndrome or genetic aortic disorder. And then we always take a family history, not quite as comprehensive as the geneticists. And then we kind of go through the revised Ghent criteria. There are a lot of people with dilated aortic roots who have atherosclerotic disease or other risk factors. So it's a lot of kind of weeding out, is this because you smoked and because you had hypertension and high cholesterol, or is this an underlying genetic diagnosis? And oftentimes it's not clear. So oftentimes in clinic we can say, okay, you know what, you have no family history, you have no physical features, so we don't, and you have other risk factors, so we don't think that you've got a heritable aortic disorder. Other people, we say, yeah, you definitely meet criteria. So then the question is, do we send you to genetics for genetic testing? Would you have children? Would you want pre-implantation genetics? All of those sorts of things. And oftentimes, if we think for sure this person has something, we send them to genetic testing or to genetics to decide on genetic testing. And then a lot of people, unfortunately, still fall in kind of this category. So where possible GAD. So a very suggestive family history, maybe a few physical features. And the question is, how do we follow these people? What do we do next? And so often what we do is we send them for an ophthalmologic assessment to see whether there are any ocular findings. We do additional imaging. So if it's only been identified on an echo, we do cross-sectional imaging to see are there abnormalities elsewhere. And then we often in these patients, most of the time, refer to genetics to say, what does the geneticist think? Is it worth doing genetic testing? Because will it come up with an answer that's helpful to the patient? So whereas before, it kind of was this first step. But now we've got multiple different layers of assessment of patients. But unfortunately, a lot of people still fall kind of in this possible category. And the question is, how do you manage and follow these patients? So a new diagnostic paradigm. So this is patients that we wouldn't have gotten before. We get a lot of letters from people saying, I had a family member that had genetic testing that was positive, and oftentimes this happens. I've had two that are pregnant and they come with the letter and say, well, I'm supposed to be followed during pregnancy because my family member has a genetic diagnosis. So then, if there's a positive gene test in a relative, you do a physical exam, you do diagnostic imaging. We always send to genetics and they decide whether or not they would test. And then the question is, what does that mean for the person? So if you have just a genetic diagnosis, but you don't have the physical exam features, you don't have abnormal imaging findings, we don't really know what that means. So what is your prognosis? What does that mean gene in will you have the disease or not, really, because that's the question that people want to know, is not whether you have the gene, but whether you have the disease. And so there's a lot of uncertainty in that, especially around pregnancy. So, if somebody has a positive gene, but there's never been a pregnancy complication in a woman, do we say you shouldn't get pregnant, or there's a high risk of pregnancy? So there's still lots of questions in that, and this is a new group of patients that we're getting that we wouldn't have got 10, 15 years ago. So where are we today? So there's more patients with genetic aortic disorders coming to medical attention than ever before. There are better education regarding risks of aortic dissection in both patients and healthcare practitioners, so that's a large improvement in what it was before. There's also improved advocacy, so groups like this that organize these meetings, so improved advocacy for quick diagnosis of dissection and cardiosurgical treatment. And then with more patients receiving a genetic diagnosis, we are gaining more information regarding phenotypic expression. So there are kind of collections of families, and well, this gene causes this and this gene causes this. So it is important to partner there. So next steps. So are we improving rate of diagnosis and outcome? So this is a paper that I think is slightly depressing, but also very important. So this was looking at patients with Marfan syndrome, and they were looking at rate of specialists in your region of presentation, and to see whether having more cardiologists, more family physicians, more ophthalmologists actually improved rate of diagnosis after dissection and treatment, and it didn't. So the outcome basically was that the density, so the density of physicians in patients that were immediately diagnosed was actually was lower than the density of physicians that were diagnosed later. So I think that the kind of take-home point from this is that, yes, it's important to have lots of cardiologists and lots of ophthalmologists and lots of family physicians, but the number is not so important as the education piece. So do you have trainees, practitioners who are familiar with these diagnoses and know how to manage them? Because it's not just having, 10 adult cardiologists, it's having, maybe one or two advocates that are able to say, okay, this is my area and I'm going to move this forward. So I thought this was important. So yes, we are improving rate of diagnosis and outcomes, but we need to work harder, I think, on educating colleagues. So current pillars of management. Patient education regarding symptoms of dissection. So this is my personal soapbox. So we know that even after diagnosis, there's a 1% mortality per hour in a type A dissection. And you can see here, this is a CT scan, and this is the tear. This is the rip in the aorta, and that's not good. So, we want people to get to attention as quickly as possible. I always ask, so in clinic, I always ask every one of my patients, do you know what a dissection would feel like? Do you know what you're supposed to do? How do you get to the emergency department? Do you drive yourself? Do you have somebody else drive you? And it's remarkable the number of people that don't know what the symptoms of a dissection would be. People with diagnosed Marfan syndrome, who say, well, I imagine that I would drop dead and that would be it. And the truth is that's clearly not the paradigm. And I think that, we all have lots of patients who, I think kind of the best story I have is a young guy who was 24. His dad had a diagnosis of Marfan syndrome and passed away at the age of 30 from a dissection. He had a dissection, went to the emergency department and said, I have severe tearing back pain. They gave him some ibuprofen and sent him home. He couldn't tolerate it, so then came back a day later. They did an ECG, they did blood work, it was negative, so then they sent him home again. The third time he came back, and again I said, did you tell them that your dad had sudden cardiac death and he had Marfan syndrome? And he said, yeah, I told them. So then he came back the third day, and thankfully they repeated the ECG, and by that time he had torn into one of his coronary vessels. So they thought he had he was having an anterior heart attack. So then they took him to the cath lab. Ralph's making a bad face. Yeah, it's a bad idea. Yeah. So they took him to the cath lab, and then in the cath lab with catheters and the dissected aorta, that's how it was diagnosed. And so I think this is somebody, and he had Marfan syndrome. He had a lot of the physical features. So I think that it's important to recognize that, yes, it's important to rely on healthcare practitioners, but there's also a big piece of patient advocacy there. So I always tell people, or mostly their partners, that if you go to the emergency department with chest pain, your partner needs to be jumping up and down until you get a CT scan, because there's no other way to diagnose this. And it's remarkable the number of people that are not aware of that. I also ask everybody to get medical alert bracelets, and instead of putting Marfan syndrome or Loeys-Dietz or GAD on the medical alert bracelet, I always ask them to get risk of aortic dissection, because, you know, if you go to the emergency department, who knows whether they're going to recognize that, okay, Loeys-Dietz syndrome with chest trauma is associated with dissection. But I had a patient last week who emailed and said, oh, I went in with chest pain and I got a really good workup. And I said, oh, great. So in Alberta, we're lucky because we have a provincial database, so we can look up all diagnostic testing that's done in the whole province. And I looked up, and he had an ECG and he had troponins drawn, and nobody had done a CT scan. So we got him in for an urgent CT scan. But I think that's, you know, but he really trusted and said, well, you know, I went in, I told them that I had chest pain, they had your letter on the computer, they really gave me a good workup. So it was the chest x-ray, the ECG, and the blood work. But so I think patient education and also patient advocacy is probably the most important piece in the acute management. So then other pillars of management. So, you know, this is the original beta blocker trial from the 90s, looking at the improvement in aortic root dimension with beta blockers. And then this is the pediatric heart network trial, looking at the comparison of losartan and beta blockers. So these are kind of still our mainstays of medical therapy to prevent aortic root dimensions. But again, there's lots more research that needs to be done. Also, exercise recommendations. So this is a difficult one. Again, this is kind of the same slide that Dr. Bradley has showed yesterday, looking at kind of heavy isometric exercise. So, you know, and things where you could have a significant hit to the chest versus more cardiovascular exercise. So counseling patients to stay away from things that could be detrimental to their aorta. And then the other one that that Dr. Gruhl talked about yesterday, so pregnancy management. So I also do pregnancy and heart disease, and this one is one that's rife with kind of concerns, and then also we just don't know. But I do think that there is a good proportion of women that, you know, having imaging pre-pregnancy, having imaging during pregnancy, having imaging after pregnancy, and even just risk education. So people knowing what they're getting into is important mentally for women who are considering pregnancy. So we do a lot of work regarding what is your risk, what does that risk mean to you, what is it a risk of? So, you know, when we say 1 to 2% risk of dissection based on your disorder, what are we talking about? So I think that's really important, and I don't know whether we've made a ton of movement in this regard. So I read a paper on Turner syndrome yesterday, looking at IVF and Turner syndrome, because I've recently had a couple of patients that are considering in vitro fertilization, and it was startling because it was a trial looking at outcomes, but of 50% of the women with Turner syndrome who had oocytes implanted, so who had IVF, only 50% of them hadn't had an echo prior. So I think it's remarkable, kind of the lack of general information among healthcare practitioners, but and I think it's important for people to advocate for themselves and know their own disease. So then moving forward, so there have been significant improvements in genetic diagnoses and phenotypic prediction. So, you know, now when we get a family with a gene, we can kind of look up and see in the literature, well, what other families do we have and how did that manifest? There are new targets for therapeutic intervention, so there was lots of information about that yesterday, so maybe we'll be able to move forward with therapeutic targets. Improvement in education of healthcare practitioners and also patients themselves about how to advocate for themselves. And then also patient advocacy. So there is a movement, and I think this is kind of a marker of that, you know, in the past, lots of medical research was done and we would say, okay, we're the researchers, you guys are the specimens, the patients, you know, we're going to do the research and set the research targets, where things are changing quite a bit, where now there's a lot of focus on participatory action research. So, you know, partnering with patients and saying, okay, you know, we have the tools to do the research, what's important to you? And I think that things are moving in that direction, where the driver of what's researched is no longer what's important to us. So again, you know, looking looking back at the diagnostic paradigm, the thing that, when I meet you, the thing that I'm worried about is your aortic root and your mitral valve. Whereas what might be the most concerning thing for the patient is their severe back pain or their hernia that's debilitating. So I think that things are moving in a direction where it's less driven from kind of the ivory tower of healthcare saying this is what we're going to research, and more driven from patients saying this is what's important to us. You guys have the tools, let's work together to move in that direction. So I would just make a pitch that if there's anybody in the room from Alberta, please come find me, because we're setting up a participant. One guy, we got one guy. Right, fair enough. Hello, yeah. Because the goal is to set forth a participatory action group for patients with heritable aortic disorders, and instead of us setting the agenda, have more of a group decision about what's important. So I'll stop there. Yeah. Okay. Thank you.
We have time for some questions, or? Yep. So if we have some questions, there's microphones here in the front. If you'd like to get up, don't be shy. So let's see who's going to be the first one to ask a question. Please. Just introduce yourself.
Hi, my name is Christy. I'm here from Toronto. I had a question about sort of CT scans and allergies. So I have anaphylaxis to shellfish. So if I go into the hospital, there's always a question. Sometimes they say it's not a worry because the contrast that they use in a CT scan could kill me, and then sometimes they say it can't. So what is the true understanding of that? Do I need to worry? Do I need to go in for my extra, stuff to make sure that I'm safe from it?
Yeah, I think so. I don't know that. Yeah. Okay. Yeah.
I can take that one.
Yeah.
Yeah.
Actually,
Oh, yes. Okay,
even
yeah.
better.
The question is shellfish allergy and iodine contrast. Yeah. So there is substantial evidence that there is iodine doesn't come from the ocean. It's been added to salt so populations are not deficient in iodine. But anything that comes from the ocean does not contain iodine. So if you have a shellfish allergy, there is no risk and no reason to give you steroids, prednisone, cortisone, prior to get this.
But that's for shellfish, right?
That's for shellfish.
Okay.
Or anything, or fish, or anything that's
Right.
a concern for allergy and from food that may contain iodine, that is thought to contain iodine. Routine radiology departments used to prepare all patients ahead of time if they were to get contrast with usually high-dose cortisone, if they have proven iodine allergy or allergy to any food from the ocean. But that practice is something of the past that should no longer recommended and no longer should be done.
So,
Most people find out they have an allergy once they've had a test with dye. So if they do have a reaction, they have a test with dye, an angiogram, or a CT scan with contrast, they're given dye and they have an allergic reaction, hives or a rash or something. Hopefully it's not anaphylactic the first time, but anybody with an allergic, if it is, then it has to be dealt with obviously as an emergency. But anybody with any kind of allergic reaction in the past, we pre-medicate the next time. So prednisone, Benadryl, etc., and we're on high alert. So it doesn't mean you can't have the test with dye, but that precautions have to be taken, and it depends on how bad that first allergic reaction is. Do you want to speak more to that, François?
Yes, so if you have a prior history of allergy, then a real allergy to the contrast agent, the dye that they give in radiology, then you need a preparation. There are two ways of preparing for that. If there's time, you can get several doses of cortisone over about 12 hours. You get 3 doses, and then you get an antihistamine ready before. If the exam needs to be done now because you're in the emergency room, it could be a CT scan. It could be an urgent angiogram if you need it because you have a heart attack. Then we can give a high dose of cortisone intravenously, and you can still go and get your exam, unless the allergy that you had in the past was what Moral referred to as anaphylactic, which means that your blood pressure dropped and your throat became tight, and you may need to have a tube put down in emergency by the anesthesiologist. So In that particular case, that's the most concerning one, and that's about the only reason where an exam with a contrast agent should be avoided unless absolutely necessary. If this is your case, then big hospitals have other options. If we're looking for an aortic dissection, we could do an MRI, which uses a different type of contrast agent, a different dye that doesn't contain iodine, so that could be one option. We can also do a transesophageal echo, which means that we could put the echo probe in your swallowing tube, and then we can see the large part of the aorta and especially the root, so it's a proven way of looking for aortic dissection. So there are ways around that.
So I'm just going to jump in. We have to be very, in Loeys-Dietz syndrome, we have a very high incidence of allergy, and an accelerated or heightened incidence of allergy. So you have to be careful from an imaging. Our second son, Thomas, had an attack. He had Gladium, I guess it was. Gladium, thank you. I can't speak this morning. But so you've got to be really alert for it, and you got to let the healthcare professionals know that with Loeys-Dietz there is a higher incidence of an allergic reaction. So again, coming back to what you said, which I really appreciate, this is up to you to be managing it for yourself. And so as a part of your, self-management here in care, if you are going for imaging, you got to say, look, I have a disease, here's what it is, there is a higher incidence potentially of allergic reaction to X, Y, Z.
Can I make a comment to that?
Yeah.
If you're in the emergency room and there's one thing if you have a proven allergy, you add a reaction to the drug or to the product that the doctors want to use, that's one thing. If it's the other thing, if you have a rare disease, that you're dealing with a physician who doesn't know everything about the disease, that you don't have a proven allergy, that you have chest pain and the doctor wants to do a CT scan, I would just caution not to frighten the doctor so much.
Yeah.
That he's going to do something wrong with a rare disease, and then he'll be paralyzed. Because you won't do a CT scan because you're telling him you might get this terrible allergy, and then if he doesn't do the CT scan, you may miss the aortic dissection, which may be life-threatening. So don't paralyze your physician.
Yeah.
That's a good point too. Yeah, this is what. Yeah. We have another question here from the floor.
Yeah, I have all kinds of allergic reactions to both CT, contrast, and MRI, the gadolinium. So if I understand correctly, you're supposed to have imaging as a Loeys-Dietz or suspected Loeys-Dietz person, but they won't do it because the allergic reaction keeps getting worse every time I have a test. So how do I deal with that?
Okay. So again, two things. Again, it depends on the severity of the allergy, and that's really.
Can everybody hear François Pierre? I just want to make sure that everybody gets the answer all the way at both sides of the room, or perhaps maybe you can speak in the microphone.
So the answer, number one, it depends on the severity of the allergic reactions that you've had to several agents, and that's a very good consult for an allergist to try to tease out what's the sequence between being exposed to something and then what's the reaction, and has the reaction ever been severe enough that there's no way that you can be exposed to that particular substance or medication or contrast agent without being prepared, and how likely is the preparation going to prevent the allergy. That's one thing that should be sorted out. The other thing for the imaging is that with MRI, we can do vascular imaging without giving contrast. So just by using the spontaneous contrast from the blood that we get on the images, the blood appears white, so the blood vessels appear white. The issue with that is that the ability to see details is not as good as an exam with the contrast. So if we're looking for something, a tiny aneurysm, something in a small vessel, it may be harder to see. So ideally, you would want to have an exam, a baseline exam with contrast, and then subsequent exams could be done without contrast, because then the doctors would know where to look. If there is an anomaly, would know that they have to target their attention to a specific segment of the vascular tree, all the blood vessels, and then that may be a way. Then that may be a way around it. So that would be these are difficult situations, especially when people have reactions to multiple agents. But sometimes also there's a risk-benefit ratio to be done, and that's really helpful to get an allergist involved at that point.
I think we have, are these questions about radiology as well? Radiological questions? Because we'll have François Pierre stay up there if that's the case. No? Okay, so go ahead.
So I heard that with these heart-related disorders, dental procedures can be risky. So I just wanted to get a final opinion on whether we need antibiotics before dental surgery.
Yeah, so I think that this is something that's changed quite a bit, and I do adult congenital heart disease as well, so there's a lot of confusion because in the past some people were told, especially with the mitral valve prolapse, oh yes, you definitely should be on antibiotics, and then they were told, no, you don't need to be on, and then sometimes they get a valve replacement, and then now you need to be on antibiotics. So with the abnormalities with Marfan syndrome, unless you have an artificial valve in your heart, or you've had endocarditis in the past, so if you've had an infection on the heart valve in the past, or you have an artificial valve, then you don't need to take antibiotics before dental procedures unless it would be the same that they would give everybody antibiotics. So if you're having a dental surgery, oftentimes they will give, a big dental surgery where they're going into the gums, they would give anybody off the street antibiotics. So in that case, you would need it. But unless you've had endocarditis in the past or you have an artificial heart valve, then you don't need to have. Yeah. And we certainly, I think the kind of message from all of that is that having clean teeth and going to see the dentist is much more important than taking the antibiotics prior. So we wouldn't want people to avoid going to the dentist because they're worried about getting an infection. It's kind of that risk benefit. So, yeah.
I was just going to say, even if you've had a valve sparing operation, so even if you don't have an artificial valve, and this is really sort of individual practices, but I still recommend for my patients to have their antibiotic prophylaxis before they get any dental work. So if you've had an operation to remove an aneurysm, but your valve was not replaced, I think there still is, because there's a graft, the Dacron graft that we use is a foreign material, and the risk of infection is really, is low, but if you do get an infection, it's a pretty serious issue. And so when you look at the risk benefit, although there's no real proven benefit of that antibiotic prophylaxis to reduce the risk of this and that, but still and I'm not sure, Maral, what you recommend to your patients that you've operated on, but I certainly recommend taking the prophylaxis.
I think it's a very important point. If you have not had any open heart surgery, any repair of your valve or your aorta, then we say you don't need antibiotics for dental procedures unless you've had an infection of the heart valve previously, unless you've had endocarditis. If you have had surgery, definitely if you have an artificial valve, you need antibiotics. Anytime you have anything that could potentially put bacteria in your bloodstream, definitely with an artificial valve. And I do what Ismail does. So anyone with a graft, I think even though it's not in the guidelines, I think the risk benefit is in favor of having antibiotics. Tim's giving me Tim's going to disagree with me.
Jean, you want to...
It will create contribution, but beyond 6 months, usually we certainly suggest people require antibiotics for 6 months after a graft is, but then beyond that we don't have any evidence, so we don't routinely sort of recommend it. So I just think you have to be aware that there is a little bit of a difference in opinion on that. I mean, in the past we treated everybody with antibiotics just because they had a heart condition, and now we've just sort of said, well, unless there's evidence, but certainly for 6 months post-operatively with a graft.
So there is disagreement, clearly. So I think we all agree that if you have an artificial valve, you should have antibiotics. If you have a graft for the first 6, and you can comment on the orthopedic aspect of it, but I also did want to say, after you've had open heart surgery, we like to avoid dental manipulation. I tell my patients, wait 6 months before you start having manipulation of the teeth. But then afterwards, it's very important to have excellent oral hygiene, to see the dentist every 6 months, and especially if you have an artificial valve or any kind of graft material. But we wait a little bit for the valve and the graft to sort of get covered with your own body cells before starting that process.
I'm Jean Ouellette. I'm an orthopedic surgeon that works out of Montreal. But the question is very relevant in the sense that, especially if you have people that have autoimmune or some immune deficiencies for which Loeys-Dietz may have some propensity or maybe not an optimal immune system. But from an orthopedic point of view, any foreign body, so if you've had a hip replacement, if you had spine surgery, these are sources where bacteria, if you get a bacteria that goes into your blood, that circulates, will like to sort of end up on those implants. So therefore, we do recommend for any deep dental procedures, so another like root canals, anything that will really expose vessels, and meaning a fair amount of blood, seeing that there's a lot of bacteria in the mouth, you may become bacteremic, and therefore, the typical antibiotics are really penicillin, and it's a relatively benign antibiotic. So the trade-off for orthopedics is that we still currently recommend prophylactic antibiotics for this minimizing the risk of having seeding one of your implants or the surgery. So similar with the grafts and so on. So I think it's a good question in trying to weigh the pros and cons is really what is the risk of taking those antibiotics versus the risk of getting into trouble. And again, the issue of having clean, a lot of people have horrible teeth, and that's one of the source where one's not really aware that you're at risk of having these deep-seated infections. So I think the trade-off for me, at least from my practice, is really I do strongly advocate to have antibiotics. But as you can see, the medical profession, you get 10 different specialties, or even all the same specialists in the same room, you get this variability. And I think one of the key messages that come out is really you taking onus of your own disease and your responsibility, and same thing with small cuts. Being very aware of this risk of seeding implants is something that must not be taken lightly. So.
Yeah.
Thank you.
I think also there's a risk benefit. It's the same as kind of the IV dye, that there's always a risk benefit. So I have one patient who has Marfan syndrome who had mitral valve prolapse, so does not, based on any guideline now, require endocarditis prophylaxis, but hadn't been to the dentist for like 8 to 10 years because was allergic to penicillins and had a reaction to clindamycin. So then you kind of think, no, go to the dentist. I think, so it's always a risk benefit. So having clean teeth is more important than, that, yes, it's protective at that one dose, but if you have an allergy, so it's always a discussion with your practitioner and then a risk-benefit decision for yourself. So, yeah.
Thank you. This gentleman here, yeah. You're Calgarian.
Yes, yeah, good.
Hi, I'm Kevin from Calgary. Hi, Kevin. No, just kidding. I've gone through 3 dissections, and it really resonated with me when Michelle spoke about that 24-year-old patient who came into an emergency room advocating for himself and not getting proper diagnosis. And the same thing happened to me. And as I'd gone into the emergency room with my wife, advocating and stating my family history, we had to fight with the emergency doc to get a CT. And the point that I'm trying to make is that, is it cost or is it risk? And the emergency doc that I was fighting with kept pointing out to me is that it was a risk.
I think there's always a concern about radiation, right? So there's a concern that, well, there's 3 to 6 millimeters worth of CT scan. Are we irradiating yet? It's not a big deal yet. But so, if you don't have a problem and you're getting a CT scan every 6 months, then yes, there's a risk that we're going to cause cancer when you're 70 years old. But if there's a concern that you're having a dissection that you could die from tonight, the radiation risk is completely negligible. But I think that from that focus, so there is lots of physician education regarding, cost appropriateness and using tests appropriately, choosing wisely and that sort of thing. And then, anytime you say, well, I have a risk of a dye allergy and that sort of thing. So they kind of weigh all those factors in. And I think without kind of proper education, there's maybe it's an abnormal, or it's a inappropriate assessment of risk, right? For somebody to say, well, there's this is how much it costs and this is the risk. But I think that sometimes you have to make a decision between being polite and dying of an aortic section, right? And it's better to live and be rude than it is to be polite and not survive. And I think that a lot of times, so the times that we hear these stories are unfortunately not like yours, where it eventually got done, but stories where it was a family member, and this is how my family member passed away, and they had, it's not, there's this perception that, oh, well, people kind of drop and that's it, but that's not how it happens. They come to the emergency department 3 times, they get given ibuprofen, and I think, so my patient that went in and with the chest pain, who had, it's available on his EMR saying that he's got a diagnosis and he should have a CT scan. When he went in, he got an ECG and he got blood work, and I looked at the triage diagnosis, because we can see the emergency record, and it said non-cardiac chest pain. So that's the thing, is I think that, in medicine, we are taught to make judgment based on how people look. Or do they look like they're in pain? Do they look like the guy that's having a dissection, which is the 60-year-old guy who smokes and who has high cholesterol and hypertension? And oftentimes our patients don't fit into that paradigm, and so based on that spot they get non-cardiac chest pain, and then that protocol doesn't happen. And so I think advocacy on your own behalf is important. Yeah, okay, sorry.
Sorry.
Okay, yeah, no, I'm out of here. Okay, all right.